Hello, everyone. My name is Dr. Eric Wamwell. I'm a clinical assistant professor at the University of Missouri Kansas City School of Pharmacy with the Division of Pharmacy Practice and Administration, and then also a clinical pharmacy specialist here at Centerpoint Medical Center. And today I'm joined by two students that are in their final year of pharmacy school at the University of Missouri Kansas City School of Pharmacy, Patricia and Amy. And today we're going to be taking some time to discuss some alternative management options for influenza virus. One of the things that we noted about the 2014-2015 influenza season is that there wasn't a very high effectiveness rate with the vaccine, only about a 20% effectiveness rate. And so what we saw was a lot of people that had the active influenza virus. And in some scenarios, not a great response to Tamiflu or oseltamivir, which is one of the neuraminidase inhibitors. And so what we want to look at today is what are some alternative options to Tamiflu that you might have patients ask you about, whether that be at the pharmacy or at your clinical practice site. One of those is echinacea, and then the other one is, I need assistance, Amy.
Oscillococcinum.
Oscillococcinum. And so those will be the two options that we're speaking about today. One of the other options that's an alternative medication is elderberry extract. We won't spend any time on that particularly today, but we will mention it as well. So with that, I'll have Amy just go ahead and get started with the one that she's taken some time to look into, discussing a couple articles that have been published on it.
The first alternative option that I'm going to discuss is oscillococcinum. It's also known as Oslo, and it's a patented homeopathic preparation that's manufactured by a French-based company, and it's marketed and widely used for prevention and treatment of influenza. It's made from wild duck heart and liver extract and then diluted several times to where there's little to no original liver or heart molecules in the final marketed product. And the exact mechanism is not entirely known, but as a homeopathic preparation, it falls under the assumption of like cures like, or the law of similars, or a small amount of something will cure what in larger quantities it causes. And so components of the heart and liver extract are similar to components found in viruses, and so that may be kind of the mechanism behind its proposed antiviral effects. And also it seems that wildfowl houses are a major reservoir for human influenza. And in theory, it may also have immunomodulatory effects, but ultimately scientific information regarding the specific mechanism of action is still lacking. So the first article I reviewed was entitled A Controlled Evaluation of a Homeopathic Preparation in the Treatment of Influenza-like Syndromes. And it was first published in the British Journal of Clinical Pharmacology in 1989. And it was the first randomized controlled trial to study or to evaluate oscillococcinum's effect on influenza. And their primary efficacy measure that they were looking at was the proportion of patients who recovered within 48 hours of starting the treatment. They also looked at their patients' judgment of the effectiveness of the treatment and whether any other medications were taken during the study period. So 478 patients were enrolled and randomized into the active treatment versus placebo group. And they included patients who exhibited an influenza-like syndrome, and they defined that as a rectal temperature greater than or equal to 38 degrees Celsius and 2 or more of what they termed the cardinal symptoms, which was headache, stiffness, lumbar and articular pain, and chills. And the first symptoms had to have occurred in the previous 24 hours before they presented. And then they excluded patients with an immune deficiency or local infection, and then people who had gotten the influenza vaccine, and patients who are under treatment for either depression or stimulation of immunity. And a majority of the information that, or the results that came from this trial were from patients, their own record of their illness. And so patients were required to record their morning and evening temperatures as well as the presence or absence of the 5 cardinal symptoms for a week. And they also were asked to make their own judgment on how effective they thought the treatment was working for them. And they also were asked not to take any medications for pain or fever during the first 48 hours, and if they did, to record that information. So moving on to the results of this study, when we're looking at the recovery rate within the 48 hours of treatment, it appears that 17.1% of patients in the active treatment group had recovered, compared to 10.3% in the placebo group, which gave us a statistically significant difference and a p-value of 0.03. Then they also broke this primary objective down to look at subpopulations of age and of severity of illness. And we saw a significant difference in patients aged 12 to 29 between active and placebo groups, but no significant difference when we looked at patients over the age of 30. And we also, when looking at the severity of the syndrome, there was a significant difference in patients who had more of a mild to moderate severity of illness, and no significant difference seen in patients with more severe symptoms. Some other things that they found was that the placebo group used a larger amount of medications for pain or fever during the first 48 hours. And then there's also a significant number of patients who made a favorable judgment of the active treatment over the placebo. There were some limitations to this study, like power was not mentioned at all in the study, and they relied purely on the patient as the main source of their information, which could be kind of unreliable, inconsistent, and lead to over-reporting of information. And then there was no serological data used to determine if the patients had the influenza syndrome or not. They just used the clinical criteria, and it maybe lacked specificity. And also, people may have been infected with different viral strains, and some studies said that oscillococcinum may be more effective in one strain versus another, and so that may impact the results of the effectiveness. And then adverse events were not reported, so that makes it difficult to assess the risk versus benefit of taking this homeopathic preparation. The next article I looked at was oscillococcinum in patients with influenza-like syndromes, a placebo-controlled double-blind evaluation. And it was published in 1998, and it was pretty much a reproduction of this previous article I described. So the primary objective was similar, looking at the effectiveness of oscillococcinum in influenza-like syndromes. And they had two primary efficacy measures. They looked at the improvement of symptoms after 48 hours of treatment, and also the recovery, the rate of recovery. And they included 372 patients in the study, and the inclusion criteria were very similar to the last study, and they included patients with a rectal temperature greater than or equal to 38 degrees Celsius. They had to suffer from muscle pain and headache, and at least one of the following symptoms, including shivering, thoracic or periarticular pain, spinal pain, cough, irritation of the nasal mucosa, and general feeling of illness. And then they also had to have those symptoms within the last 24 hours. And exclusion criteria were very similar to the last article. Monitoring here, they still relied on some patient information recorded in journals, but they also relied more on clinicians and their evaluation of the patients, which may be a little bit more reliable. At the start of the trial, the clinician recorded just general patient information, including any other diseases they had, their rectal temperature, their symptoms, additional medications they were taking. And then after 48 hours, the clinician gave kind of a global impression of any changes in the patient's symptoms. And then the clinicians then again assessed at the end of the trial, which is anywhere from 7 to 10 days, depending on the patient. And then the patients were asked to write in a journal twice a day, every day for 5 days to record their temperatures and any medications taken, and rate symptoms relating to the flu. So looking at the results, the primary outcome, which is the change in patient symptoms 48 hours after the first dose, we see that 43.7% of patients in the active treatment group had clearly improved, compared to 33.5% of patients in the placebo group, which is a significant difference with a p-value of less than 0.05. And then also looking at complete resolution of symptoms, we found that at the end of the second day, so after 48 hours, 17.4% of patients in the active treatment group had no symptoms, compared to 6.6% of patients in the placebo group. And then after 5 days of treatment, 26.4% of patients in the active treatment group had not yet eliminated their symptoms, compared to 32.3% of patients in the placebo group had not yet eliminated their symptoms, and this was statistically significant as well. When you look at the final assessment at 7 to 10 days, there was not a significant difference between the two groups, which just kind of proves that this alternative treatment may be less effective as the course of the illness just kind of resolves itself, which makes sense because it is self-limiting. There was a few reports on adverse effects in this study. There was 5 reported adverse effects, but according to the opinion of the physicians, 4 of the 5 were not related to Oslo, and only 1 patient suffered from headache, which may have been caused by Oslo. Some limitations of this study was that power was not mentioned, and we weren't given p-values for all of the outcomes, so it was kind of hard to determine the statistical significance of some of the results. They were very vague in the reporting of their adverse events, and the study was performed with connections to the Boren laboratory, which is where this is manufactured. So kind of summarizing this and seeing how we can apply it to our practice, the patients that took the active treatment saw a faster recovery rate than patients taking placebo, and they also took less additional medications for fever and pain. Also another important fact to look at is that in the first study, it seemed that younger patients and patients with more mild to moderate severity saw a greater improvement than placebo. However, we should look at this data cautiously, and the author of the first article even stated that it would be unwise to claim that the study has demonstrated a cause and effect relationship between the drug and their recoveries. So it's not reasonable to rule out the possibility that this could be beneficial in the treatment of flu, but we currently can't make strong recommendations on the use of it for treatment. There just have been few randomized controlled trials, so ultimately we need more research to determine the proper place for this in therapeutic recommendations.
Very good. Yeah, so those both of those articles are older articles, older research, but that's what we're going to find with some of these alternative therapies is, one, if there's any literature available, it's not going to be the best literature, but that's kind of our purpose for today is what is out there on these interventions. Just get a sense for, is there any positive results in the utilization of these alternative agents. One of the things that you noted was that no difference at 10 days on that second study, which should be what we expect when we look at influenza viruses, because it is a self-limited infection that should be resolved by approximately day 10. And so with any therapy that we're going to use for influenza, patients should be better by day 10, no matter what the intervention is, because the disease illness should be done by then. And then what was the other thing that I wanted to point out? I don't know. I think it's going to escape me for now. But, okay. Something that we can potentially utilize. Don't have a good feel for the side effects, though. That wasn't really well reported in either of those two studies.
Exactly.
Okay. Very good. But superior to placebo.
Yep.
In those two. Great. Okay. Patricia.
Yes.
You're going to tell us about echinacea.
Sure.
A couple studies that you found in regards to it.
Yeah.
Great.
So echinacea is an herb. It's also commonly known as American coneflower. A total of 9 echinacea species are identified, but only 3 are being used medicinally. In this video, I'll talk about studies on echinacea for the treatment and prevention of influenza. How does the echinacea work on flu? The flu viruses can induce pro-inflammatory cytokines, causing the flu symptoms like fever. A study showed echinacea extract prevented the production of the pro-inflammatory cytokines, which in theory may reduce the flu symptoms. Echinacea also contains other bioactive chemicals like cichoric acid, caffeic acid, alkalamides, and polysaccharides, which are believed to have immunomodulatory activities. What that means is it helps regulate the immune system. Other in vitro studies suggest that echinacea had antiviral activities against several different strains of influenza viruses. So next we'll look at the efficacy and safety of echinacea in human studies that are out there. The first article is titled Safety and Efficacy Profile of Echinacea purpurea to Prevent Common Cold Episodes, a randomized double-blind placebo-controlled trial. This study is primary This study's primary objective is to investigate the safety and efficacy of echinacea purpura extract in the prevention of common cold episodes in a large population over a 4-month period. Similar to other studies on echinacea, this study included echinacea's effects on colds and upper respiratory tract infections as a whole. There's a few trials out there have been done specifically on echinacea and influenza. For the purpose of this journal club, we will look at the safety profile and some of the data comparing echinacea versus placebo in their prophylactic effects against viruses, including influenza viruses. There were 755 healthy study participants recruited into the study, 355 patients in the echinacea group and 362 patients in the placebo group. Adults of good physical condition that experienced 2 or more colds per year were included. For monitoring, all patients received 1 month of treatment and a questionnaire-based diary for daily recording of adverse reactions, cold-related symptoms, and the use of any concurrent medications, and they followed up and picked up the study medication monthly for 4 months. And the participants also received 3 nasal swab kits to be used during acute cold episodes and screen for viruses. For the secondary efficacy analysis, 24 nasal swab samples in the echinacea prophylaxis group and 47 in the placebo group tested positive for membranous viruses, including influenza virus. This result was statistically significant with p-value of 0.014. As a prophylaxis, echinophores, the echinacea group had a strong antiviral effect when compared with the placebo. And to demonstrate that echinophores was non-inferior to placebo in safety, the researchers reported non-inferiority margin of 10%. And so there should be less than 10% difference between the proportion of patients with drug-related adverse reactions in the 2 groups. So they found 9.9% of participants in echinophores and 9.7% of participants in placebo group reported drug-related adverse events. The difference was less than 10%. Some of the limitations of this study included that the researchers were not able to draw more detailed information about the viruses due to the low overall number of samples. And 2 of the 5 authors did not disclose the conflict of interest. Also, the study relied on the participants to report their symptoms and record their daily findings, and there's a lot of inter-rater variability. So, as previously mentioned, there is not much evidence while looking at echinacea as sole product versus influenza treatment. In fact, some of the echinacea studies on respiratory tract infections specifically excluded flu patients. So the next study we'll look at is a combination of echinacea and elderberry as an antiviral. It's titled Echinophores Hot Drink versus oseltamivir in Influenza, a randomized double-blind, double-dummy, multi-center, non-inferiority clinical trial. This study is exciting because it's the first in vivo trial to compare an echinacea-containing product with Tamiflu. It's a standard prescription treatment used to decrease the length and severity of influenza symptoms with early intervention. The primary objective of this trial is to study the efficacy and safety of Echinophores Hot Drink versus Tamiflu as a treatment in newly diagnosed flu patients. And they measure that by accumulated proportion of patients with flu symptoms relieved or recovered after 1 day, 5 days, and 10 days of treatment. The study included children and adults aged from 12 to 70 with acute influenza symptoms. 473 patients were enrolled in the study and randomized into 2 groups. 203 patients in the Echinophores Hot Drink group and 217 patients in the Tamiflu group were included in efficacy analysis. The inclusion criteria were clinical diagnosis of influenza based on the presence of at least 1 respiratory symptoms, cough, sore throat, nasal symptoms, 1 constitutional symptom that included headache, malaise, myalgia, sweats, and or chills or fatigue, and fever greater or equal to 37.8 Celsius, with symptoms not present for more than 48 hours. A negative pregnancy test, a body weight of greater than 40 kilograms, and good general health. As far as monitoring, the patients received a physical exam, blood pressure and heart rate check, and provided blood and nasal secretion samples at inclusion. The patients received a diary to record influenza symptoms daily over the 10-day treatment period. After the treatment period, patients returned to the study center for closeout visits, and adherence was monitored. As far as efficacy, the primary efficacy endpoint focused on the proportion of recovered patients. Recovery from illness was comparable between Echinaforce hot drink versus Tamiflu group. 50.2% versus 48.8% after 5 days. 90.1% versus 84.8% after 10 days. It's not statistically significant, but there's higher percentage of patients recovery in Echinaforce hot drink group. The same primary efficacy analysis was applied to a subgroup of 41 patients with confirmed influenza viruses by the nasal swab. Recovery from illness was comparable again between these two groups, 45 in Echinaforce hot drink versus 42.9 in Tamiflu group after 5 days, 95 and 76.2 after 10 days. So again, you can see there's a higher percent of patients recovering in Echinaforce hot drink group. Echinaforce hot drink is considered to be non-inferior to Tamiflu in relieving flu symptoms when the lower limit of confidence interval was above the NI margin of 0.42, and the results after day 1, 5, 10, and combined analysis of all 3 days were all greater than 0.42. So the symptom relief efficacy of Echinaforce hot drink was non-inferior to Tamiflu treatment. As far as safety, 1.7% of Echinaforce hot drink group and 2.2% in Tamiflu group reported study medication-related adverse events. Overall, although the difference is not statistically significant, 2.46% in Echinaforce hot drink versus 6.45 in Tamiflu reported respiratory or gastrointestinal complications. Nausea and vomiting adverse events were more frequently reported in the Tamiflu group with 15 reports, and the Echinaforce hot drink group had 3 reports total. Some of the limitation with this study is the study was sponsored by A. Vogel Bioforce. This is a manufacturer for the Echinaforce hot drink. One of the authors that was involved in writing of the study protocol and manuscripts is an employee of this company. And 2 authors received honorary from the sponsor of the study. Echinaforce hot drink contains both echinacea extract and elderberry as active ingredients. So while I'm looking at echinacea in alternative influenza treatment, elderberry in the study is a confounding factor. So we're unable to evaluate Tamiflu versus echinacea's sole effect on flu. The study relied on the patient's self-reported symptoms and adverse events, so there's high inter-rater variability. And finally, all patients in this case were Caucasian. While I was reviewing articles on this topic, researchers in different echinacea studies used different formulations of echinacea products, which often contain different ingredients and doses. It was difficult to compare the various formulations in the studies. And for consumers out there who are purchasing echinacea products, the inconsistency may be confusing while they're looking for a specific formulation. Overall, from this efficacy standpoint, Echinaforce hot drink was comparable to Tamiflu in alleviating flu symptoms. Prophylactic Echinaforce demonstrated greater antiviral activity towards respiratory viruses than placebo. Echinaforce hot drink had lower risk of adverse events than Tamiflu. The Echinaforce hot drink may be an alternative to Tamiflu in treatment of acute influenza, but I think further studies would benefit from inclusion of pure echinacea extract versus Tamiflu and use of a standardized echinacea preparation in the studies and independent researchers not employed by the manufacturer of the study medications.
Great. Okay, so we have the first study that was specifically an echinacea strictly product and showed similar outcomes or better outcomes to placebo. Better?
It showed better outcome in antiviral activity.
Okay, great. And then we had the second one that was a combination of the echinacea elderberry as a drink in comparison to oseltamivir or Tamiflu that showed equivalent outcomes there. So some good evidence here to say that there may be some value to utilizing echinacea as an antiviral, specifically in influenza A infections, and as well as the oscillococcinum nothing thing. So when patients ask about these different products, there is some evidence for them to be utilized in influenza virus, particularly in reducing symptoms. That was the other thing I was going to note about the first couple of studies, and now these other two studies is there's no evidence here about reducing hospitalizations or reducing progression to a more severe influenza infection. These were strictly looking at symptom reduction, which is a pretty typical outcome, primary outcome for the different antiviral influenza A management pharmacotherapies. So there you go. There's some additional information to take with you and think about as we're approaching the influenza season. Remember to get your vaccination. It's the same vaccination as we had last year, though. So hopefully we'll hit it this year. We won't miss on that H3N2 2013 Swedish genotype this year. Okay. So long, sayonara.